Hello, welcome to the North Carolina Pharmacists Association webinar series. We appreciate your participation in this presentation titled Acute Care Antimicrobial Stewardship, What's in a Name? Following the webinar, please be sure to follow the instructions alongside this webinar's link on the NCAP website to obtain CE. NCAP members will receive 1 hour of free NC-CE credit. Our speaker today is Stephanie Weisberg, who graduated with her Doctor of Pharmacy degree from the University of Florida College of Pharmacy and pursued her PGY1 training at St. Joseph's Candler Health System in Savannah, Georgia. She's currently completing her PGY2 Infectious Diseases residency at Novant Health Presbyterian Medical Center. Stephanie has a passion for infectious diseases pharmacotherapy, including treatment of resistant gram-negative infections and HIV, and plans to pursue a position in antimicrobial stewardship and/or HIV management. I will now turn it over to our speaker, Dr. Weisberg.
Thank you so much for that introduction. Hello, everyone. Today, I will be discussing acute care antimicrobial stewardship and all that title entails. By the end of this presentation, we should all be able to define antimicrobial stewardship and its role in the acute care setting, review national initiatives supporting antimicrobial stewardship, evaluate key components of an antimicrobial stewardship program, and highlight the pharmacist's role within antimicrobial stewardship. So to begin, what is antimicrobial stewardship? The Infectious Diseases Society of America defines it as coordinated interventions designed to improve and measure the appropriate use of antimicrobials by promoting the selection of the optimal antimicrobial drug regimen, dose, duration of therapy, and route of administration. This is just one of many definitions out there, but every definition that I've looked at had a few key elements in common. One, antimicrobial stewardship is a coordinated effort. This means that it takes a team of individuals working together to achieve a common goal. Number two, antimicrobial stewardship involves optimizing the utilization of antimicrobial agents. While some people think of stewardship as policing antibiotics, the true goal is optimization of antimicrobial therapy. And number three, antimicrobial stewardship is multifactorial. Stewardship programs employ multiple strategies to optimize antibiotic use on many levels. We mentioned that stewardship is a team effort, so let's discuss who should make up that team. The Joint Commission requires, at minimum, an infectious disease physician leader, an infection preventionist, a pharmacist, and an additional practitioner. Additional staff members could include a quality improvement personnel member, an information technology specialist, laboratory staff, as well as nursing. Why exactly is stewardship so important to the acute care setting? The CDC collected data from multiple studies and found that up to 50% of all antibiotics prescribed in the acute care setting in the United States are either unnecessary or inappropriate. Overprescribing of antibiotics has been shown to increase the incidence of adverse drug reactions, Clostridium difficile infections, and antimicrobial resistance. Current estimates from the CDC show that over 2 million people are infected with resistant organisms each year, and of those, approximately 23,000 result in death. Additionally, the CDC published a list of the top 18 drug-resistant threats to the United States. As you can see here, this list is broken down into 3 categories: urgent, serious, and concerning. Among the most urgent threats is Clostridium difficile, or C. diff. While C. diff is not typically resistant to the drugs that treat it, it is directly related to overprescribing of antibiotics and the practices that have contributed to the resistance epidemic. The other 2 threats in the urgent category are carbapenem-resistant Enterobacteriaceae and drug-resistant Neisseria gonorrhea. Both of these are of major concern because we are running out of drugs to treat them, with some isolates currently having no available active agents. These threats exemplify the need for antimicrobial stewardship to reduce antimicrobial resistance and preserve our therapeutic options. A recent meta-analysis by Bauer and colleagues looked at 32 different studies to evaluate the impact of antimicrobial stewardship programs. They found that antimicrobial stewardship programs are associated with reduced incidence of Clostridium difficile infections, as well as reduced incidence of infection or colonization with resistant organisms, such as multi-drug resistant gram-negative bacteria, ESBL-producing gram-negative bacteria, and methicillin-resistant Staph aureus. They also found that stewardship programs had more impact when they were combined with infection control measures, such as hand hygiene initiatives, thus emphasizing the importance of a team-based approach. The overall goals of any antimicrobial stewardship program should be fairly consistent. The first goal is to optimize treatment of infections. This involves ensuring each patient has the best drug, dose, duration of therapy for their particular infection. The next goal is to reduce antibiotic-associated adverse events, including C. diff infections. Unfortunately, antimicrobial agents are not benign. By ensuring proper dosing and avoiding unnecessary extended durations of therapy, we can minimize the harm caused by antibiotics. The third goal listed is to reduce antimicrobial resistance. By utilizing antibiotics only when necessary, de-escalating early, and avoiding excessive use, we can reduce overall resistance. The final goal is to improve quality of patient care and patient safety. This goal is best achieved by achieving the first three goals. Judicious use of optimized antibiotics improves overall patient care. Over the past decade, antimicrobial stewardship has been a growing topic of interest, with several national initiatives created to specifically support this effort. The momentum really started to pick up in September of 2014 with the issue of Executive Order 13676 by President Obama, which triggered the development and release of the National Action Plan for Combating Antibiotic-Resistant Bacteria in March of 2015. By June of 2016, the Center for Medicare and Medicaid Services began requiring an antimicrobial stewardship program as a condition of payment and published their proposed criteria for meeting requirements. The following month, the Joint Commission released guidelines for antimicrobial stewardship with the aim to begin enforcing the standard in January of 2017. The Joint Commission Antimicrobial Stewardship Guideline consists of 8 key elements required for meeting the standard. Fortunately, these elements closely coincide with the CDC Core Elements. In fact, Joint Commission Element Number 5 states that the hospital's antimicrobial stewardship program should contain the CDC Core Elements. Because of this overlap, I will be discussing the Joint Commission elements in conjunction with the CDC elements. In 2014, the CDC published the Core Elements of Hospital Antibiotic Stewardship Programs, a guidance document outlining the components necessary for an effective stewardship program. They identified these 7 components or elements listed here. Those are leadership, commitment, accountability, drug expertise, action, tracking, reporting, and education. We will delve into each of these on the following slides. The first element is leadership commitment. This coincides with Joint Commission Element Number 1, which states that leaders establish antimicrobial stewardship as a priority. This is critical to the success of an antimicrobial stewardship program. Support from leadership is more than just a financial commitment. Some of the methods suggested for leadership to show support are making formal statements of support for stewardship efforts and antibiotic use monitoring, inclusion of stewardship-related duties in job descriptions, ensuring relevant staff are afforded sufficient time to dedicate to stewardship activities, and support of stewardship training and education. Additionally, financial support does affect the capacity of a stewardship program and the initiatives that it can sustain. Fortunately, there is an abundance of literature available that shows that between antibiotic cost savings and indirect savings, stewardship programs tend to pay for themselves in the long run. Aside from citing the Joint Commission requirements, a great way to get leadership on board with starting or expanding a stewardship program is to cite the evidence. A study by Gross and colleagues evaluated 180 patients to compare recommendations made by an antimicrobial management team that included a pharmacist backed up by an ID physician to those made by ID fellows alone. As you can see, the antimicrobial management team outperformed the ID fellows in the measured outcomes with higher percentages of appropriate recommendations, higher cure rate, and lower incidence of treatment failures. This study shows the large impact that a stewardship team, including a dedicated pharmacist, can make to patient care. The next two elements, accountability and drug expertise, go hand in hand. These elements most closely coincide with Joint Commission element number 4, which outlines the requirements for the antimicrobial stewardship team members. As you can see, these elements point to the need for a single physician leader, as well as a single pharmacy leader, to be held responsible for the program. It is recommended that the official leader be a physician, as there has been great success with facilities that have programs structured this way. Typically, that physician is ID trained. However, facilities without specific ID physicians, hospitalists are often appointed to this role. Many smaller facilities have seen great success with a hospitalist leader because hospitalists are involved with the majority of antimicrobial prescribing that takes place within a hospital. Similarly, the pharmacist co-leader is typically an ID or stewardship trained pharmacist. However, this is not a requirement. Additionally, even without formal residency training in infectious diseases, any pharmacist can become certified in antimicrobial stewardship through programs I will discuss towards the end of this presentation. I am skipping the action element for a moment and moving on to tracking and reporting, which also go hand in hand. These elements involve the monitoring of antibiotic prescribing and local resistance patterns, the tracking of process use and outcome measures, and finally, the reporting of findings to relevant parties on a regular basis. This ties in with Joint Commission element number 7, which states that a hospital should collect, analyze, and report data on its antimicrobial stewardship program. One of the metrics we have been tracking at Novant Health is fluoroquinolone use, measured in days of therapy per 1,000 patient days. As you can see, we have been tracking this data since January of 2015, when it was first suspected that our use may be higher than desired. There has been a steady decline in use since then, with a slight drop around the time of the FDA warning statements and the addition of more ID pharmacists to the health system. Because we still weren't where we wanted to be in terms of overall usage of fluoroquinolones, reducing use became one of our system-wide goals for 2017. This brings me to education. The education component of stewardship helps tie all of the other elements together. The Joint Commission actually has two separate elements related to education. One is that hospital staff be educated about antimicrobial resistance and stewardship practices. This education should occur on initial hire, and then periodically thereafter based on the needs of the system. Here at Novant Health, we include this in our new hire training as well as our required annual training. The other component is patient education. This element states that patients and their families, if necessary, should be educated on the appropriate use of antibiotics. The thought behind this is that with enough education, patients will understand that not all infections require antibiotics and that antibiotics are not benign. The hope is that in time, we can change the culture of antibiotic prescribing. The CDC additionally emphasizes that clinicians should be educated regularly on optimal antibiotic prescribing and issues of antimicrobial resistance. This education is most effective when paired with corresponding interventions and outcome measures. Providing facility-specific information on antibiotic use and prescribing patterns can be a motivational tool. This brings me back to our fluoroquinolone initiative. With the additional ID pharmacists, we were able to make more day-to-day interventions, as well as to provide system-wide education to the hospitalist groups. Providers were educated on the risks associated with use of fluoroquinolones, as well as our institutional susceptibilities for Pseudomonas and other organisms that make them poor empiric options. Later in the year, our pneumonia order sets were updated, and information was presented to the hospitalists on fluoroquinolone use by facility. All of these efforts combined have resulted in an incredible 51% decrease in overall fluoroquinolone use across the health system. I skipped over action before because this is the most intensive element. This element correlates with Joint Commission Elements 6 and 8. Element 6 states that the Antimicrobial Stewardship Program should use organization-approved multidisciplinary protocols. Element 8 states simply that hospitals should take action to improve any opportunities identified by the Stewardship Program. In order to meet the action core element, at least one of these recommended actions should be implemented. The categories of interventions are policies, broad interventions, pharmacy-driven interventions, and infection or syndrome-specific interventions. The first category is implementing policies. This involves implementation of policies that support optimal antimicrobial prescribing and helps to aid the success of a program. One of the recommended policies is requiring documentation of dose, duration, and indication for all courses of antimicrobials. This not only allows for ease of monitoring and tracking, but also helps guide recommendations. The second suggestion is to develop facility-specific treatment recommendations. These should reflect not only national guidelines, but also local susceptibilities and institutional formulary options. It should include recommendations for both antimicrobial agents and duration of therapy. This is an example of those recommended policies in action here at Novant Health. Here we see an order for piperacillin tazobactam. As you can see, when you go to enter the order, you're required to enter both an indication and a duration before it will let you submit the order. As a helpful reference, we have included a link here to the Novant Health Treatment Duration Guideline that was created by one of our ID pharmacists and approved by the health system. This is a section from the document that would be pulled up. You can see here it has various infections, recommended durations, and then more information for infections such as UTIs, where duration may vary by agent. All of these steps were designed to streamline the process of ordering optimal antibiotic therapy upon initial entry. The second action category is broad interventions. This is further broken down into antibiotic timeout, prior authorization, and prospective audit and feedback. Antibiotic timeout is a system for clinicians to review the antibiotics they have prescribed and evaluate if they are still the best choice. Clinicians should review antibiotics 48 hours after initiation to answer these 4 questions. Does the patient have an infection that will respond to antibiotics? Providers should determine whether the cause of the infection is truly bacterial or if it is more likely a viral infection or other inflammatory process in which antibiotics provide no added benefit. If it will respond to antibiotics, is the patient on the right antibiotics, dose, and route of administration? This is where optimization of dosing and IV to PO interchanges come into play. The third question is, can a more targeted antibiotic be used to treat the infection? In other words, can we de-escalate? By this point, we may have culture results back to drive therapy and streamline antibiotics from broad agents to more targeted therapy. The final question is, how long should the patient receive antibiotics? This is where we may be able to shorten durations for patients who are improving rapidly. While this process is intended to be performed by the provider, many health systems have also implemented similar strategies for ID pharmacists to review patients that have been on antibiotics for 48 hours and make recommendations to providers as necessary. The next broad intervention type is prior authorization. Prior authorization is the restriction of certain antibiotics for review and approval by an ID expert prior to initiation of the medication. This allows for a thorough review of the patient and any alternative options before turning to a restricted agent. While effective, this strategy can be resource intensive as it requires an expert to be available to review the antibiotic order in a timely manner. Restrictions may be based on spectrum of activity, cost, toxicities, or any combination of the 3. Some of the commonly restricted agents are carbapenems, extended spectrum cephalosporins, anti-MRSA agents, and fidaxomicin. The final broad intervention is a prospective audit and feedback. This is an external review of antimicrobial therapy by an ID expert, usually an ID-trained pharmacist plus or minus an ID physician. Prospective audit and feedback differs from antibiotic timeout because it is performed by someone outside of the treating team. This is designed to provide an objective view of current therapy and opportunities to optimize the regimen. This strategy has been highly successful, particularly in the care of critically ill patients or those on multiple or broad antibiotics. However, like with prior authorization, it requires that an ID expert be available to thoroughly review patient cases and make recommendations. The third action category is pharmacy-driven interventions. Pharmacy-driven interventions are those that many institutions have in place, but may not think of as stewardship activities. One of these is IV to PO interchanges. Many health systems have policies in place to allow pharmacists to automatically convert certain highly bioavailable medications for patients that meet set criteria. Other institutions have a list that is reviewed by pharmacists with recommendations made to providers for the final change. Another common intervention is renal dose adjustments. This is important not only for those with poor renal function, but also for those with fluctuating or recovering renal function. This is an area in which pharmacists can make a big impact and truly optimize therapy for each individual patient daily. Along those lines, we have dose optimization. This includes pharmacy to dose protocols for antibiotics such as vancomycin and aminoglycosides, as well as extended infusion beta-lactam dosing and other pharmacokinetic pharmacodynamic dosing strategies. Next, we have duplicate therapy alerts. One of the most useful situations to use this is with dual anaerobic coverage, such as a patient on both piperacillin tazobactam and metronidazole. The only time this is necessary is a patient with C. diff and another concomitant infection. So it is usually an easy and effective intervention to make. Finally, we have our time-sensitive antibiotic stop orders. This is mainly referring to surgical prophylaxis antibiotics, in which duration is highly dependent on the procedure performed. All of these strategies are things that every pharmacist can do every day to aid in the stewardship efforts. The final action category is infection or syndrome-specific interventions. These interventions target infections or syndromes for which prescribing habits may differ from guideline-recommended therapy. Some of the recommended infections listed here are CAP, UTI, SSTI, and C. diff. CAP, UTI, and SSTI are common infections for which duration does not match evidence-based recommendations. This is an area where a stewardship team can tie in all of the core elements to track average durations for each of these infections, choose one to target, educate providers, and then monitor durations after education and report results. Clostridium difficile is another infection that is a good target for intervention. We mentioned earlier that it is one of CDC's urgent threats, and it is also the most common healthcare-associated infection. Profiles of patients with C. diff should be reviewed thoroughly to remove any bowel regimens, antidiarrheal agents, or other contributing medications, such as unnecessary antibiotics or proton pump inhibitors. It is important to remember that this is only a list of suggested infections. Any area for improvement identified at your institution can be a target for infection-specific intervention. The IDSA has published guidelines on implementing a stewardship program. I want to touch on a few of their suggestions that were not included in the CDC Core Elements or the Joint Commission standard. The first recommendation is for the use of computerized clinical decision support at the point of prescribing antibiotics. A 2016 study by Busing and colleagues looked at the outcomes associated with electronic antibiotic stewardship. They compared usage before and after implementation of a computerized antimicrobial approval system. If you look at the graph on the right of the screen, you will see two trend lines on each. The solid line is the trend prior to implementation, and the dashed line is the trend afterward. The top graph shows glycopeptide utilization, whereas the bottom one is showing carbapenem usage. As you can see, the study found that there was a decrease in usage of broad-spectrum antibiotics after the implementation of this computerized approval system. They also found a significantly lower rate of resistant organisms after implementation. Another recommendation by the IDSA is to perform penicillin skin testing. Penicillin skin testing should be used to assess patients with beta-lactam allergies and potentially optimize therapy based on results. One prime example of a benefit from this is the ability to change a patient with MSSA bacteremia to nafcillin or cefazolin if the skin test is negative. Given that these are the drugs of choice and have shown superiority over vancomycin for methicillin-sensitive Staph aureus, this definitely has a chance to improve patient outcomes. A 2017 study by Trubiano and colleagues looked at the impact of allergy testing combined with stewardship efforts on patient outcomes. Not surprisingly to most of us who have been working in healthcare, they found that on average there were 1.91 documented antibiotic allergies per patient. They also found that allergy testing, in combination with stewardship efforts, resulted in the removal of at least one allergy in 83% of patients. Additionally, they saw an increase in the prescribing of narrow-spectrum penicillins and other beta-lactams, as well as a decrease in the prescribing of restricted antibiotics. The IDSA guidelines also include some microbiology and laboratory recommendations. The first of these is to create and distribute stratified antibiograms. Stratifications can be done by location or by infection source. Here I have an example of our neuro ICU antibiogram at Novant Health Presbyterian Medical Center. I also pulled out the Pseudomonas line from our overall antibiogram for comparison. You can see here that the susceptibilities for certain agents, such as cefepime, are much different than those for the general population. This information can be extremely useful to providers when deciding on an empiric regimen. The next laboratory recommendation made by IDSA is to utilize selective or cascade reporting of antimicrobial susceptibilities. This can help minimize the use of broad-spectrum agents such as carbapenems for very susceptible organisms. Here I included an example of a typical panel for a Pseudomonas aeruginosa. As you can see here, it's a pan-sensitive organism with several options to choose from. This would be a more selective antimicrobial susceptibility report. This streamlines therapy, gives 5 options from different classes, and includes options for various allergies or other situations that could occur. You can also notice that I eliminated carbapenems from being reported because this was a pan-sensitive organism. We want to reserve carbapenems and other very broad agents for those who cannot use some of our narrower agents. Another area recommended by the IDSA is the use of rapid diagnostics wherever possible. Rapid diagnostic tests should be performed on blood specimens in addition to traditional cultures. These can be utilized to identify common causative organisms as well as certain resistance genes, which varies based on specific technology. This information provides helpful diagnostic tools that give us an identification of an organism within hours of culture positivity. If you look at the chart on the right, you can see the time to positive rapid diagnostic test shortens the duration quite a bit from the point where we would even have preliminary reports of organisms with a standard blood culture. Rapid viral testing should also be performed to assess for the presence of viral respiratory pathogens. This can help us differentiate between bacterial and viral infections, providing evidence to discontinue antibiotics if it's positive. Here I have a comparison of 2 of our most common rapid diagnostic tools. BioFire Film Array and Veregene are both PCR-based rapid diagnostic tools. While there are various different panels, including blood, GI, respiratory, and meningitis, here I'm focusing on the blood culture panels. BioFire Film Array is one combined panel that reports on gram-positive bacteria, gram-negative bacteria, yeast, and certain resistance genes. While this is not all-encompassing, it does capture some of our most common organisms identified. Veregene, on the other hand, has 2 separate panels, a gram-positive panel and a gram-negative panel. While this rapid diagnostic tool does not identify yeast, it does, however, identify more organisms within the gram-positive, gram-negative organisms. Additionally, it has 3 times the number of resistance genes, which can be extremely helpful in identifying a treatment strategy prior to having susceptibilities. Some of our more advanced rapid diagnostics are the Accelerate PhenoTest blood culture kit and MALDI-TOF. Accelerate PhenoTest is a direct from sample test which does not have to be plated and cultured prior to performing. The samples do not have to incubate, and it can be taken directly from the blood sample. The entire process is done with one kit, and it takes only 2 minutes from load to the start of running the test. With this test, you can have identification in less than 90 minutes and antibiotic susceptibilities in less than 7 hours. This tool could greatly affect the speed at which we can identify organisms and target antibiotics to more effectively treat infections. MALDI-TOF, or Matrix-Assisted Laser Desorption Ionization Time of Flight, is another rapid diagnostic tool that can be used not only on blood samples, but other samples as well. The way this process works is that a sample is mixed with the matrix and then applied to a target slide. That slide is then irradiated with a laser, causing ionization. The ions are guided into a flight tube, and then mass spectrometry is performed, identifying the organism. Any of these rapid diagnostics can greatly assist in streamlining antibiotics for our patients. Now that I've discussed all of the core elements and what goes into an antibiotic stewardship program, I want to focus on the pharmacist role within an antimicrobial stewardship program. So pharmacists in a health system should be participating in policy creation. Pharmacists will also likely be the ones performing stewardship interventions, tracking and monitoring outcomes, as well as educating providers on antimicrobial stewardship. To break it down further, the role of an ID pharmacist is a little more specific. ID pharmacists should be proposing and designing new policies or updates to existing policies. They may work with a team or task force to get new initiatives passed and continually improve antibiotic stewardship initiatives. They are also responsible for the dedicated high-level interventions. This would include our prior authorizations, prospective audit and feedback, and many of our infection or syndrome-specific interventions that we discussed earlier. The ID pharmacist is also typically the one responsible for tracking and reporting outcomes of stewardship interventions, antimicrobial use, and resistance patterns. And as we discussed, this should always be paired with education of staff. Clinical staff pharmacists also play a role in antibiotic stewardship. These are the pharmacists that are typically responsible for our pharmacy-driven interventions. Every pharmacist has the opportunity for stewardship interventions every day. Clinical staff pharmacists can also perform some of our infection or syndrome-specific interventions. For example, you can recommend guideline-based durations of therapy for infections such as CAP, UTI, SSTI, or really any infection that does have a guideline-based duration. Pharmacists can also recommend that we obtain an MRSA nasal PCR for patients with pneumonia. Oftentimes, we have patients on vancomycin for pneumonia, and we have no way to de-escalate because they're culture negative. With the high negative predictive value of MRSA nasal PCR, this is a way that pharmacists can impact patient care and get the patient off of unnecessary antibiotics. Additionally, pharmacists can participate in culture-driven antibiotic escalation or de-escalation. Oftentimes, when pharmacists are verifying orders or reviewing profiles, we see culture results prior to the physician. If you see a culture result and you notice that an opportunity for de-escalation, or perhaps you notice a drug-bug mismatch, this is a great opportunity to make that intervention and contact the provider. Pharmacists also have the opportunity to use interventions to educate providers on evidence-based recommendations. For those pharmacists with an interest in infectious diseases who did not complete a specialty residency, there are some options available. Both MAD-ID and SIDP have antimicrobial stewardship programs. And coming soon, BPS Infectious Disease Pharmacy will put out a test. It's not currently available, but the first exam is expected to be in September of 2018. More information on that is forthcoming. The MAD-ID Antimicrobial Stewardship Training Program does not require pharmacists to have any ID experience prior to enrolling. There are currently 2 programs available. The basic program, which is designed to teach basic skills and provide an overview of antimicrobial stewardship practice, needed to develop an antimicrobial stewardship program. This is a 3-component program that consists of online modules, live programming via online lessons and teleconferences, and a practical component. The overall cost of this program is $500, but there are discounts for groups, trainees, and those in developing nations. Additionally, they have an advanced program, which is designed to meet the needs of pharmacists, physicians, and other providers that have some antimicrobial stewardship experience and/or basic skills in this area. This one consists of 2 components, a didactic component presented at the annual meeting, and a practical component as well. The cost of this program is $250, and again, there are discounts for groups. Of note, MAD-ID does not have any basis for who gets to participate in which program. They leave that up to the participant, whether they feel they need the basic program or could benefit more from the advanced program. The SIDP Antimicrobial Stewardship Certificate Program also requires no prior experience to enroll. This program structure is an innovative and intensive practice-based activity for pharmacists focusing on the pharmacist's role in the area of appropriate use of antimicrobial agents. This, again, is 3 phases: a self-study phase, live webinars, and then a skills component completed in the practice setting. As you can see, this program is a little more labor-intensive, requiring more hours of study prior to receiving certificate. The cost of this program is $750 with, again, discounts for groups and trainees. One thing to note is that many institutions will provide funding for programs such as this if you can propose the benefit and how it will help the system. Here I have some future directions for antimicrobial stewardship programs. First, we have pediatric antimicrobial stewardship. This is an up-and-coming stewardship initiative that typically would include the creation of a separate antibiogram and separate treatment guidelines. Pediatric patients experience very different infections and have very different resistance patterns than adults do. So it makes sense that we would have a separate stewardship focus for that patient population. Similarly, emergency department antimicrobial stewardship is a hot topic right now. Some options are to create an emergency department specific antibiogram, Again, this would be more of our outpatient antibiotics and those who do not get admitted, looking at the susceptibility patterns there and targeting our best options for therapy. This also could include real-time interventions on verification, so making those interventions up front when the antibiotics are ordered, rather than going back and trying to change things after the fact. Finally, there's the option to target our problem antimicrobials. So based on tracking data and figuring out which antimicrobials are a problem at your institution, for instance, at our institution, the fluoroquinolone data I presented earlier, the emergency department is a great place to start with targeting those orders. The third area for future directions is outpatient parenteral antimicrobial therapy, or OPAT. This is typically used for some of our infections that require long durations of therapy in the outpatient setting. Some of these are bacteremia, endocarditis, osteomyelitis, and septic arthritis. Targeting antibiotics and streamlining therapy appropriately in these settings can go a long way towards preventing things like C. diff and antimicrobial resistance. Some take-home points from the presentation. Antimicrobial stewardship is a collaborative team effort aimed at improving patient outcomes, optimizing antimicrobial therapy, and reducing collateral damage. Almost every study I presented included an antimicrobial stewardship team in addition to some initiative. This really shows that the collaborative effort goes a long way at improving outcomes. Second, antimicrobial stewardship has become a nationwide focus and is now required by accrediting bodies. Throughout the presentation, I showed you the CDC Core Elements and the Joint Commission standards and how to meet each of these standards. And then finally, every pharmacist has the ability to make stewardship interventions every day. Some of the activities we're performing on a day-to-day basis may not seem like stewardship, but things such as IV to PO interchanges, renal adjustments, and vancomycin dosing are included as stewardship interventions. And with that, I thank you so much for your attention. I hope you enjoyed the presentation. Please remember, if you want to claim CE, to follow the link or to follow the directions included with the link to this presentation. Thank you.